Hello everyone, welcome to the medical recap. I hope you're doing good. In today's video, we are going to talk about cardiac tamponade. Here's an overview of what we are going to cover today, going from the general definition and reminders to the clinical picture and the treatment. Lass uns anfangen. I want you guys to really focus on the definition and the reminders because it's the key to understand the physiopathology. Cardiac tamponade is a large and or a rapidly evolving pericardial effusion. What does that mean? What makes difference between the usual pericardial effusion and the cardiac tamponade? Every cardiac tamponade is a pericardial effusion with specific characteristics. It's all about the pericardium ability to stretch and absorb the fluid pressure. By this logic, the usual pericardial effusion can be or turn into a cardiac tamponade in two cases. 1. The fluid builds up slowly until it surpasses the pericardium abilities to stretch, drifting the compression towards the right chambers of the heart. 2. The fluid builds up insanely fast regardless of the quantity, not giving enough time for the pericardium to stretch, drifting the pressure towards the right chambers of the heart. When the compression of the fluid is focused on the heart, we have cardiac tamponade. Before moving on to the causes, we need to talk about some blood pressure key aspects and cardiogenic shock reminders. Blood pressure is related to the cardiac output and systemic vascular resistance. The cardiac output is related to the stroke volume and heart rate. Stroke volume is the amount of blood ejected from the ventricle with each cardiac cycle. You should know that in the normal case, in the healthy state of the body, the systolic blood pressure is slightly lower during inspiration than expiration. Why though? Because the intrathoracic pressure during inspiration is lower, leading to an increased venous return, the lower pressure sucks in blood from the inferior and the superior vena cava. So the right ventricle expands in all directions, including the septum, to acquire the extra blood volume, which leads to a small septal shift and compression of the left ventricle during inspiration, reducing the end diastolic volume and the stroke volume as a result. Lower stroke volume leads to a lower cardiac output and a slightly lower systolic blood pressure during inspiration. But since the right ventricle is expanding in all directions, the septal shift is small and the difference is no greater than 10 mm of mercury. Moving on to the cardiogenic shock. But first, what does a shock mean? A shock is an inadequate tissue perfusion leading to ischemia, necrosis, and even organ failure. There are various types of shock: cardiogenic, hypovolemic, obstructive. Our main focus today is the cardiogenic shock, which happens when the heart is unable to pump enough blood, leading to hypotension. It can be caused by any alteration of the pump, like myocarditis, congestive heart diseases, and of course, cardiac tamponade. But what causes the cardiac tamponade? Well, we have various etiologies, starting with bacterial viral infections and autoimmune diseases, which usually cause the usual pericardial effusion, like we talked about in the pericarditis video. But if the fluid keeps building up, or the infection is really severe, it can turn into a cardiac tamponade. Type A of aortic dissection is a common cause of cardiac tamponade. An aortic dissection is a serious condition in which a tear occurs in the inner layer of the aorta. There are three types depending on the location of the tear. As shown in the picture, type A involves the ascending aorta and may progress to involve the arch and the thoracoabdominal aorta. Blood can erupt and flow back to the pericardium, causing cardiac tamponade. A blunt or a penetrating cardiac trauma, such as stab wounds and gunshot wounds, can cause a hemopericardium and severe cardiac tamponade. We also have the left ventricular wall rupture, which is a rare and a dangerous complication of acute myocardial infarction. When an MI occurs, the damaged tissue is replaced with granulation weak tissue with the yellow color in the picture, which is the risk factor for left ventricular wall rupture as shown with the big arrow. Multiple other factors can lead to the rupture, such as age and sex. A ventricular wall rupture can also be caused by trauma or infections. Our last cause is neoplasia, either by contiguity, like lung cancer and breast cancer, or by systemic ways, like non-Hodgkin lymphoma. Enough with etiologies, let's move to the clinical picture. We have 6 main symptoms that are mostly compensation mechanisms to the cardiogenic shock. The main symptom of the cardiogenic shock is hypotension, which results from the reduced blood inflow and the preload due to the fluid pressure against the right heart. Since the blood pressure is related to the cardiac output, the body will try to increase the heart rate, leading to our second symptom, tachycardia. Also, the body will try to increase the venous return. And as we said in the reminders, the venous return is already better in the inspiratory phase. So, the patient is going to try to make his inspiratory phase longer and more frequent, leading to dyspnea, which can be the chief complaint and a compensation mechanism to the hypotension. Since the blood inflow is reduced, it will start to backflow to the inferior vena cava and the superior vena cava, giving us our fourth symptom. Blood flowing back to the inferior vena cava will result of an hepatomegaly and pedal edema, while blood flowing back to the superior vena cava will result of jugular vein distension. Moving on, remember the friction rub sounds in the pericarditis? Here the fluid may be too large, so the heart sounds are muffled and decreased, because the fluid acts as a barrier between the heart and the stethoscope. We may have a friction rub instead when the quantity of the fluid is small but rapidly evolving. Our last symptom is something called pulsus paradoxus. Remember when we said that the blood pressure is slightly lower during inspiration because of the increased venous return? In the case of a cardiac tamponade, the right ventricle will try to expand in all directions, like normal. But that's impossible due to the fluid pressure, so the right ventricle will expand mostly towards the left ventricle where the pressure is lower, as shown in the picture, causing a major septal shift during inspiration and a difference of blood pressure greater than 10 mm of mercury. So, as a quick recap, the patient is going to suffer from hypotension and try to compensate it by a reflex tachycardia and dyspnea. He will also suffer from jugular vein distension and pedal edema. His heart sounds are muffled and his blood pressure during inspiration is lower. For your exams, you should know that Beck's triad is a collection of 3 symptoms indicating cardiac tamponade: hypotension, muffled heart sounds, and jugular vein distension.
Hey, I have a question. How's the fluid pressure is only focused on the right chambers of the heart?
Good question, Ous. The consequences of the fluid pressure are more focused on the right chambers of the heart because they have thinner and less stronger walls, comparing to the left side of the heart. As simple as that. Trying to figure out what's going on, you need to run some tests. Starting with an EKG, you may find sinus tachycardia, microvoltage, and electrical alternates as shown in the picture. A chest ray can be helpful, showing a large cardiac silhouette which gives the heart the shape of a water bottle, as shown in the picture. But really, the gold standard test for the diagnosis is an echo, showing a pericardial effusion, of course, the huge septal shift and the collapse of the right chambers during inspiration, but also a dilated inferior vena cava. The diagnosis can also be confirmed with pericardiocentesis, which is also the treatment. Hemodynamic improvement after pulling the fluid off confirms the diagnosis. The treatment consists of pericardiocentesis and sometimes surgical drainage in severe or recurrent cases. But you are no cardiologist, right? You can't perform a pericardiocentesis. So while waiting for the cardiologist team, you need to keep the patient alive with a mean arterial pressure higher than 60 mm of mercury, using IV fluid and vasopressors. The mean arterial pressure is calculated with Lian's formula. It's the systolic blood pressure plus double the diastolic blood pressure, all split by 3. IV fluids, most used are lactated arrangers, increase the MAP by increasing the end diastolic volume. Vasopressors, most used is norepinephrine, increase the MAP by increasing systemic vascular resistance and cardiac muscle contractility. You should know that vasopressors are more active during cardiogenic shock. You should avoid intubating the patient because dyspnea and respiratory movements are an important compensation mechanism, and by intubating the patient, you're gonna stop the respiratory movements. So, as a quick recap, cardiac tamponade is a large and or rapidly evolving pericardial effusion causing cardiogenic shock. A cardiogenic shock is an inadequate tissue perfusion due to an alteration of the pump, which can be caused by aortic dissection, left ventricular wall rupture, trauma, and neoplasia. Clinical picture consists of hypotension, muffled heart sounds, and jugular vein distension, which forms Beck's triad. But we can also have dyspnea, tachycardia, and Persis paradoxis. The diagnosis can be confirmed by echo findings. The treatment is based on pericardiocentesis, IV fluids, and vasopressors. That would be all for today's video. I hope you enjoyed. You can download the material and the mind map used in this video following the link in the description box. Don't forget to subscribe to our channel. Thank you all and bis zum nächsten Mal.